Today, we are here talking about navigating chronic pain and opioid use disorder. This is the Navigator Focus series, and so we're happy to have you. And thank you for joining us. My name is Sherrie Cisneros. I'm the Navigator Program Director, and CA Bridge is a part of our overall Bridge organization. We have many branches, and we are CA Bridge, and we are under the umbrella of Public Health Institute. We also are funded by California Department of Health Services. So that's who we are. Today, we just want to make sure that for the best experience, the number one thing to read on this slide is use the chat for questions and address it to everyone. And Alicia likes a lot of engagement. So please put your questions in the chat and we're going to help her, guide her to answer those questions. So if you think of something, you don't have to wait, put it in there and we will let her know. So she likes that engagement. So make sure, again, that you address it to everyone so everybody knows what you're talking about. So our goal here at CA Bridge is 24/7 access to substance use navigation and addiction treatment in every hospital. So we're almost at our goal. So CA Bridge model, just a quick review, three-prong approach, low barrier treatment, connection to care, and a culture of harm reduction. This is what guides our whole model. And again, it starts with the patient getting low barrier MAT treatment, that's the docs, and the navigators follow up with connection to care and culture of harm reduction. So we thank you for all of the hard work that you're doing and spreading this low barrier treatment model throughout the state and nation and the nation. So our objectives today are listed here. These are for our CEU learners. You will get one CEU for today. You must complete the evaluation to get the CEU. So we really want to encourage you, when you get the post-event email, you have 1 week to complete. And we want to make sure that you're aware. Keep your, if you get a certificate, keep these certificates. They're very important for if you are a CHW and you need to renew your license, you have to have 6 CEUs. So that's why we're really pushing, make sure you get your post-event email, complete the eval within 1 week, and you will get certificate. So with that, I am going to introduce Dr. Alicia Gonzalez. She is, like I said, one of our most requested and favorite leaders here at Bridge to do our trainings. So again, we're honored. She's also an emergency room physician, as well as the director of CA Bridge Physician Training. And not only that, national as well, right? You do national work. And so I'm going to hand it off to Alicia and let her know what she can kind of tell you. She does so much, I can't keep up with her. How many MATs have you started, MAT programs in California? Like, you're everywhere. So we thank you for just supporting us and taking the time and being here today.
Awesome. Thank you so much, Sherrie, for that introduction. And I really, honestly, like I say this every year when I get invited back to this, but I love coming to talk with the navigators. You all are just such a crown jewel of this program, and I really believe in the impact and the power that all of you have as this like army of patient advocates. And so while today we are going to emphasize on what feels like a very clinically heavy topic, my hope is that by giving all of you sort of an introductory level, if you will, amount of information about this clinical thing, what I hope that you'll be able to do with it is to advocate to your clinical champions or your local emergency department leadership to maybe do some training with the doctors and the PAs and the NPs and the nurses to help them do a deeper dive. We have those trainings available, but also really to equip all of you with some tools that you can use to talk to your patients. Because that is one thing I think navigators are so amazing at, is translating what the doctors and the PAs and the NPs say into like regular human understandable language. You all have that skill so much better than basically anybody else. So with that, again, it's going to be kind of a little bit clinical, but with the idea here that I want to give you the tools that you'll need to be able to help our patients. So Of course, we don't have any financial disclosures. Nobody from pharma is paying me. I just care about this stuff a whole lot, and we all know buprenorphine works, and that's why we talk about it. So we are going to talk a little bit about the intersection of chronic pain and opioid use disorder, and really the fact that this is like one spectrum of the same thing, right? A lot of our patients who have OUD do struggle with chronic pain, and a lot of patients with chronic pain end up on opioids, and so they become patients who have opioid use disorder, maybe not addiction, maybe not struggling from some of the more social consequences that can come from drug addiction, but certainly with life complications that come from being on opioids for a very long time. So, when we think about opioids, we usually look at, okay, well, what's causing death, right? And all of us know fentanyl, 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 carfentanil, right? These new synthetic, very high potency, like really, really strong opioid drugs that are out there. But what we often forget is that prescription opioids, that's what the RX means, so prescription opioids have also seen an increase, unfortunately, increase in number of patients who are dying. So, but in the 20-ish years between 2000 to 2023, this data always lags, by the way, by a couple of years, but we saw a fourfold increase, meaning 4 times the number of people are dying from prescription opioids. This is still a problem. It's not as many people as the 100-fold increase in fentanyl related deaths, but it's a big deal. And it's something we have to really think about. And when we look at that overall, you can see this arc, right? Yes, there have been years where we kind of are doing a little bit better here and there, but the overall trend is up, is the wrong direction for the number of patients that are dying from prescription opioids. And so we want to treat patients with pain. We want to do a good job with their pain, but we don't always want to turn to opioids right away. So first, before we continue on, I want to ask all of you, so please put your comments in the chat for me really quick before I give you my answer. Why is this challenging? Why is treating chronic pain difficult? And so that I can see the chat, I'm going to stop sharing for a hot second here. But tell me, why do you think? What is the problem? Why is it a topic that makes all of us uncomfortable? Why is it difficult for our patients? Ooh, I love that, Danielle, because pain is subjective. Yes, it's different for everyone. Clinicians don't have objective ways we can measure it, and so it makes it difficult. Yes, Tambra, thank you. Your dependence on opioids can grow over time. Your demand for that medication, ability to control pain can get harder. Rebecca says doctors are wanting to just do opioids and they're nervous about puke. Right. So I would call that a knowledge gap. Clinicians have a knowledge gap. They don't feel comfortable with maybe what is the better medication, but they don't know that medication as well. And so sometimes we hesitate to change our practice because of that lack of knowledge. I'll wait one more second. Anybody else? Having a pain management, Jerome says, having pain management that is consistent with their provider. Oh my gosh, the fact that we even silo pain management, we make it sound scary. We put it in another category like, ooh, you have chronic pain, you need a specialist. We can't even let your regular doctor manage it. I mean, it's kind of stigmatizing, right? Like it doesn't actually help. So these are great comments. All actually, some of them aren't even things that I was going to mention. So thank you for sharing those thoughts. But the point of this whole, exercise is that it is challenging. It's really challenging for different reasons. And I want to go over a couple that I thought of when I was prepping this. And so much of the time, as with everything we talk about with OUD, stigma. Stigma is behind a lot of the reasons that things are challenging. And in this case, it originates often from our own personal history and life experience. A lot of clinicians have had moments with patients who have chronic pain that were not positive encounters, that were really difficult encounters. And I'm sure that you as navigators can admit that sometimes the patients that you talk to are not the easiest people, right? We're not always the easiest people. Everybody's got their bad day, but we definitely have personal experiences and our own personal truth that informs what we think about chronic pain. They can be tough to manage. We don't always have the right answers. We don't want to keep giving hydromorphone or Dilaudid is a good example, like these like strong medicines. We don't like doing that, and so it makes us feel kind of icky. Another one is that many healthcare providers, honestly, have not received extensive pain management training. They don't know about all the other ways they can treat pain that are not opioids. And if you get taught in residency and medical school that this is the best way to control pain and you're not comfortable knowing the safety and how to use other medicines, that knowledge gap actually cripples us. It doesn't give us enough tools in our toolbox. That's a genuine barrier, right? It's not subjective, stigma ridden. It's more, I don't feel comfortable. And so I'm not sure what to do. And that education can be lacking. Also, not everything that we learn is true. Think about all the examples of times when you as a navigator have been told something and you're like, that is absolutely not real. Like people saying, it's actually against the rules for me as a doctor to write a prescription for buprenorphine. No, it's not. But at some point, somebody told you that, or maybe it used to be true. We used to have to have an X waiver, and now we don't. But maybe you learned the X waiver rules, and now the rules have changed. So sometimes the things that we quote unquote learn or that we're told are rules aren't rules. Another good example of this is the pain contract. A lot of clinicians think that patients in chronic pain must have a written pain contract and that we have to adhere to it. That's absolutely not true at all. There's nowhere that there's a law or a rule that a pain contract is a thing. And what we actually have found is that it can be really, again, crippling to our ability to help the patient in front of us when there's this like arbitrary list of rules about what I can and cannot do for the person in front of me. So that's not a real rule either, but maybe we did learn that from our hospital or from our colleagues. We've also not given our patients the tools that they need to succeed. Let's be real, we're bad at talking about pain. If somebody starts on insulin, we have this whole series of how we talk about insulin. Like, here's how you measure your blood sugar. Here's when you should take extra insulin. Here are the dangers. Keep it in your refrigerator. Here's how you do XYZ. Here's how you should change your diet, yada, yada. For pain, we're like, oh, too bad you broke your leg. Here's a prescription for 11, Norco tablets. Thoughts and prayers, go follow up with your primary. What? Like, that's not actually helpful. We're not helping our patients understand how to manage their pain and what they can do, what tools they have to succeed at home. So we're not taking the time to do that. And that's a place that I think navigators can be super helpful. And then finally, you know, I think it's difficult for us to wrap our heads around this initially, and then it just makes so much sense, which is that chronic pain management and opioid use disorder are the same. And I want to be clear that, remember, not all OUD is addiction, right? So addiction, the definition of addiction, involves opioid dependence, but also those like psychosocial elements where maybe someone is struggling with interpersonal relationships, stability of your employment. Maybe you're interacting with law enforcement or correctional officers because of your drug use. That's addiction. People who have built dependence, who need opioids for their body to function normally, who socially use drugs, who are on chronic pain medication, that's not addiction. But it is opioid use disorder. It is opioid dependence. And so chronic pain is on the spectrum of opioid use disorder. And because we don't always think of it that way, we forget that some of the resources we have for patients with opioid use disorder are also available for patients who have chronic pain. And since we separate them in our brain, it's a missed opportunity that we could get these patients into better care. So, far more important than what are all the problems is, what can we do about it? First things first, it is important for all of us, clinicians or not, to understand pain management goals. And this is because if we don't know what the goals are, how do we tell our patients what the goals are, right? So, first and foremost, we want to consider both medication and non-medication ways to help with pain. There are plenty of studies that show that simple things like laughter, distraction, social engagement, treating your depression, ice, heat, elevation, physical therapy, all of that stuff can help with pain. And I didn't even say the name of a medicine. So, not forgetting those alternative ways that we can help with pain. And then also knowing about opioids as a tool in our toolbox, but not as the first thing that we go to, right? We need to be better about knowing how to use those for severe pain. They're really important. I will never stop using opioids as an emergency doctor, nor should we. It's important to have a tool for like, you broke your femur, you're having a heart attack, you have appendicitis. Like, there's lots of times when we do need really strong pain medication, but not all the time, right? And we have all these other ways that we can treat pain. And so what we do is we want to target the multiple receptors in our body that perceive pain. Opioids work on this receptor, the opioid receptor, or the mu receptor, MU, the mu receptor. And what happens is that we get so distracted just trying to hit this one receptor, we forget that there are all these other ways we feel pain, and that a better approach is to do multiple pain receptors at once to get synergy across all of those together. And then being able to discuss all of this openly with our patients. What are the goals of our pain management? What are the potential side effects of being on an opioid long term? What are patients' options? For example, buprenorphine, instead of being on something like methadone or oxycodone or hydrocodone or any of that stuff, morphine long term. And then really thinking about how do we take the time to educate our patients in a compassionate way on a stepwise, holistic approach to their pain management. And then also remembering that sometimes the right the right avenue of connection to care for them could be your MAC clinic, could be the Bridge clinic. It might be this patient is a great candidate for buprenorphine and would do better with a provider in the outpatient setting who's well versed at that. We have an entire hour-long lecture for clinicians on alternatives to opioids in treating pain. And so I'm not going to make you learn all of those medicines today. It's very clinically heavy, but what I want you to take away from this is to know that we have that training. And so if you think that the doctors and the PAs, the NPs at your ER or your hospital need this, please let us know and connect us to your clinical champion. And one of our clinical implementation leaders can give this presentation to them or can share the recorded video. It's me, surprise, spoiler alert, I'm the lecturer. But I do a lecture on this topic and we're, happy to share that video with anybody. We have it for CME or even on our YouTube channel. But what I want you to appreciate about this slide is how long this list is of medicines, none of which are opioids. We've got acetaminophen, common brand name would be Tylenol. The NSAIDs like ibuprofen, naproxen, ketorolac. We've got IV and topical lidocaine. We have what I like to call the people relaxers, benzodiazepines like alprazolam, lorazepam. Some brand names that are common here would be like Ativan, Xanax, Valium, those kinds of medications, but also quote unquote muscle relaxers. They don't relax muscles, they relax people. But baclofen, medicines like that can be helpful. Gabapentin is a good medicine for nerve-related pain. Ketamine is a medicine that works on something called the NMDA receptor. Dexamethasone is a steroid that can also be used as a pain medication. And then we have all kinds of procedures we can do. We can like numb people's arms if they have a broken wrist. We can, give nitrous oxide for procedural sedation instead of drugs. So there are all these options that we have that we sometimes just forget about. And then really important, the concept that to treat pain, you have to understand the human. And this is a thing that navigators are experts at. You all are really good at helping with patients who have substance use disorder because you know how to ask them about how they got here. What was their journey? What was their trigger? Why do they struggle? And if we can't diagnose those underlying core issues, that root causes that got us here, we're going to miss. And the same is true with chronic pain. Patients can have depression, anxiety, psychosocial stress. Maybe someone died, someone went to jail. They don't have stable income. They don't have food security. Maybe they had an injury that started their chronic pain that never got better. Maybe there is like a fear or an underlying emotional component to it. Maybe they are chronically disabled. Maybe they suffer from isolation and loneliness, which do cause physical pain. Not like fake, it's in your head because you're sad. That's not what I'm saying. These things, physical pain, are associated with chronic behavioral health underlying diseases as well, and they're very real. And if you don't treat both, we're never going to win. So we have to take a whole person approach, and navigators can be so helpful in helping to identify some of those root causes and guide our clinicians toward addressing those root causes instead of forgetting about them. So I'm not going to do a deep dive here, but what I want to show you is one example. Let's say that there's this man, his name is Javier, he's 33, he was moving a couch and ooh, he felt a pop in his back and now he's got what sounds like classic sciatica. He's got this back pain, it kind of shoots down his leg. We see this patient all day, every day in the emergency department. 5 times a day, I see a patient like this. And let's just say that for the sake of argument, there's nothing making the doctor or the PA or the NP worried about this patient for like broken bones or infections, okay? We're talking about just a bad pop in the low back, but it's really bad pain. And this patient can't even walk and they're not sleeping very well. This is what it could look like for us to treat that pain. Again, I'm not going to deep dive and you don't have to memorize this. That's not your responsibility. But what I want you to see is how many medicines are on this screen, none of which are opioids. And they're all extremely effective medications. And in addition to doing acetaminophen, ibuprofen, gabapentin, a lidocaine patch, maybe an injection of ketamine, dexamethasone, a person relaxer, I can also do a trigger point injection to release their muscle knot. I can try massage. We can do heat. There are so many things we can do, none of which is addictive, none of which leads to opioid use disorder. So what I would love for you to appreciate is like, wow, that's a long list of tools in the toolbox. And we want to make sure that our clinicians have a chance to be educated on all of these. And that's what our implementation leader team is so excited to do. So if your doctors or your PAs, whatever, need this training, connect them to us. We would love to do that. Another really common thing that happens, let's say Javier actually injured his back when he was doing construction 5 years ago, and he has a work-related injury and he has chronic back pain, and he's already on hydrocodone 10s, 3 times a day, and he's had 2 back surgeries, and he comes into the ER because his pain is really bad. Well, what happens is we always end up saying, oh, well, this patient's already on hydrocodone, or he's already on morphine, or he's already on whatever. We better just give him more opioids because this patient has such a high tolerance already. In reality, that's the wrong answer. Remember how we were talking about the receptors? Well, all of the opioids only act on the mu receptor. And patients who have chronic pain who say things like, Tylenol doesn't work for me or ibuprofen doesn't work for me, what they mean is that it has not been successful at managing their chronic pain. And I understand that. I respect that as their life experience, their true experience. However, I also know that acute flare ups of pain are inflammatory. And so, even though acetaminophen, Tylenol, ibuprofen doesn't control their pain all the time, when they are having an acute flare up, that's still the right medication. And they're already taking hydrocodone or an opioid and it's not working. Why would I just keep giving more opioids? Like it didn't work already. Why are we thinking that's the only thing that's going to work? It already proved that it didn't. And so we're back to those same exact pain management goals, which is to use non-opioids as first line in mild to moderate or acute on chronic pain, like flare-ups of chronic pain, and then also using opioids when necessary as second line or a rescue medication, but optimizing that treatment by hitting multiple pain receptors and not just ignoring all of them and hitting that opioid receptor over and over and over, which is just silly. It's just not smart, and we can be smarter than that. Also, though, to do this successfully, we got to talk to our patients about it because they rightfully, like they don't understand. No one's taken the time to explain that to them. And if our clinicians don't expect it, or don't understand all of it, how could our patients, right? So we have to spend a little bit of time doing some expectation setting. This is a great example of a place where navigators are better, I think, at adopting real people conversation language than sometimes our clinicians are. It takes a lot of practice for a doctor, PA, et cetera, to get really good at this. And I think our navigators, you all just come by it so much more naturally. And so I want to equip you with some of these phrases that you can help with. For example, saying to the patient, wow, it sounds like, you've really been struggling for a long time and you're in a lot of pain. I'm confident our team can help you to bring that down today, but we're probably not going to get to zero. Like you've had this pain for however many years. The goal isn't zero, but it's to move from this pain that's not tolerable to a level that is tolerable, a level where you can walk to the bathroom, a level where you and I can chat and maybe you forget about your pain for a minute, a level where you can actually sleep at night. For us as clinicians, we will tell our patients, I understand that you think what you need is opioids. The problem is that's not safe. And I took a pledge, a vow to keep you safe. And I have lots of things I'm going to do to help you, but I can't do something that I feel like is not safe for you. And starting you on all these opioids isn't actually safe. Emphasizing to our patients, the body needs time to heal. Pain is not an insta fix. That's how we got in this problem with opioid prescriptions in the first place, right? Is that we the medical community, this is our mea culpa moment because of pharma, but we did it. We told everyone that oxycodone is safe and we can stop your pain right away and you should never have to be in pain. Breaking that cycle, reteaching all of our patients is going to take some time. And so we have to emphasize injuries take time to heal. Pain takes time to heal. You might have some pain for a long time and some pain is okay. But our goal again is to hit that tolerable level of pain, to break the crisis that you're feeling today, to address that crisis. And so we can compassionately walk our patients through that difference. This is really ultimately medically what that means is that we have to talk about a stepwise approach to managing pain. And so, one thing I would love for you as navigators to do is to take this concept. You could screenshot this, or I'm sure we'll share the slides with you at the end. We always do. But you could take this idea and put together like a handout that you could fill out with your patient. You could have your clinical champion or the doctor seeing the patient, whoever, like tell you the recommendations. And then you could be the person who helps them walk through learning this, which is that it is a stepwise approach, not just when you have pain, take an Orco, when you have pain, take an Oxy, right? It should be first prevention. The first step to managing chronic pain is preventing chronic pain. And that's going to be addressing social isolation, making sure you actually have things that bring you joy, that release dopamine in our body through normal ways. Thinking about diet and exercise. Movement is medicine. Are you being active enough? Are you going outside? Are you getting the natural vitamin D from the sunshine? Are you eating foods that are not inflammatory foods? Are you eating a healthy, well-balanced diet? A lot of pain and chronic suffering comes from our gut. So can we feed our gut a wide variety of fruits and vegetables and whole grains and things that literally have been proven to improve our mental health? And then are we, again, investing in that emotional well-being, in our whole person humanness, to prevent all of that pain? Then when you do feel pain, what do you do? And the first steps should be simple things like anti-inflammatory, acetaminophen, ibuprofen, and then also non-medications, ice, heat, elevation. Maybe you use an A strap if it's an extremity problem. Is it your back? Do you need to go to physical therapy? Do you have stretches and strengthening exercises that you've learned that you should be doing? And then for moderate, we're going to think about adding other adjuncts, maybe lidocaine patches. Again, your job is not to memorize all these medications, but it's to help patients understand this stepwise approach. And then at the severe breakthrough pain level, that's where opioids come from. Really, we don't want our patients taking oxycodone 3 times a day every day, because over time, as was mentioned in the chat already by you, those medicines stop working. We build tolerance. They actually make our pain threshold lower. They cause something called hyperesthesia, which means that the pain that we feel actually becomes more painful over time when you take opioids. So we got to help our patients understand these stepwise approaches. And then don't forget about buprenorphine. Buprenorphine is a fantastic pain medicine. And so while patients might take this for opioid use disorder, and we do think about it when they're in withdrawal, we forget sometimes that chronic pain patients might benefit from being on bupe. And so we don't always have to be at the same doses of bupe. But if you do see a patient who's on, say, chronic oxycodone or methadone or hydrocodone, whatever, that patient should probably be referred to an MIT clinic or a bridge clinic. Now, I do recommend that you reach out to your particular clinics that you work with and talk to those providers first, because maybe not all of them will feel comfortable, but I'm going to guess that 90+% of them will. So it's a conversation you should have, is what kinds of patients with chronic pain like would be good to refer to a bridge clinic, to a MAC clinic. And honestly, if a patient is on chronic opioids, they're probably a great candidate to be referred.
Alicia, we do have a question in the chat.
Yeah.
Going back to, I think, the previous slide about where is BOOP on this chart of
Yes.
the steps in management? When would that come into account? That's the question.
Great.
Where is BOOP on this chart?
Good question. So it's not on this chart because for most patients who end up on buprenorphine for chronic pain management, it's going to become one of their everyday medications. But what I would say is you'll notice that in the red severe breakthrough pain box, it does say may include opioids. It says steps 1 through 3 and then may include opioids. Remember that buprenorphine is an opioid. It's a very safe opioid. It's a very effective opioid, but it is. And so the average patient who has chronic pain may not need to be on opioids at all. But if you have somebody whose body is dependent on opioids already for pain management, and they have that, I would consider severe chronic pain, right? If they're on oxycodone every day, hydrocodone every day, that patient has severe chronic pain that's difficult to manage, then that patient probably could be switched to buprenorphine as a daily medication for them. The average patient who, let's say, hits steps 1, 2, maybe 3 sometimes, like occasional ER visit for a dexamethasone shot, that patient probably doesn't need buprenorphine. But if a patient has reached the severe breakthrough pain, they're going through steps 1 through 3, it's never working, or they're on chronic opioids already, those patients are great candidates for buprenorphine for chronic pain. Awesome. All right. And then for patients who are already on buprenorphine, sometimes those patients do have acute pain, right? They have new pain on top of chronic pain, or let's say they never had chronic pain, but they did have opioid use disorder. They're on buprenorphine, then they break their leg, or they twist their ankle, or they fall down at work and break a rib, right? These things happen to everybody. What do you do? Well, we can use buprenorphine to help control their pain. So this is really important, and things that I think are helpful for navigators to know, because again, I don't expect you all to know all the medicine, but you are so helpful at guiding our clinicians to the right resources. That's one of my favorite things about you, is saying, have you seen this protocol from, from the French program? So we have 2 separate protocols about managing acute pain for patients on bupe, but really important concepts to know is we do not stop the buprenorphine. We keep it on. It's actually really hard to manage pain in a patient who's usually taking buprenorphine if we take it away. So we want to leave it on. We want to think about all those other receptors I mentioned, making sure we hit all those other multimodal, multi-receptor approach. And then we can take a person's daily buprenorphine dose and we can separate it out into more frequent doses. The reason is because buprenorphine works really like over a long term, like 24 hours, to treat withdrawals and to treat cravings. But the pain dosing of bupe actually rises and falls on a shorter timeline, like 4 to 6 hours. So let's say a patient is on 24 milligrams of buprenorphine every day, and they take it once a day, or maybe they're on it twice a day for 12 milligrams twice a day. Okay, very common dose that we see. But now they have a broken leg. Well, we can take that 24 milligrams, leave it the same, and just divide it up more frequently. They could take 6 milligrams 4 times or 4 milligrams 6 times a day, whatever works. So that lets the pain management come up and down. Then, after dividing it up, we can even bump that dose up. So we can use buprenorphine, titrate it up while they're in pain, and then come back down slowly back to their normal level, their typical dose, once that pain, that injury is more under control. So again, I don't expect you to know those details, more just that conceptually, we should keep the buprenorphine there. We can divide it up into smaller doses. We can increase that dose. And then we want to think about other medications. And then finally, if a patient is being hospitalized or having a surgery or something, we can give full agonist opioids on top, but we just have to keep the bup on, keep the bup there. And then it is okay to give morphine or hydromorphone. A common brand name there is Dilaudid. A lot of people know that. Dilaudid or, fentanyl, any of those medicines, we can give it. We just got to keep the buprenorphine on board. And so showing your clinicians these protocols that we have can be really helpful. So I would encourage you to make sure that your clinical champion has seen these and has shared them. I don't expect you to know them, more just to help our doctors and our PAs and stuff know that they exist.
Okay, Alicia, before
Yeah.
we go on, Tamara is saying if a patient is on chronic opioids or methadone for chronic pain for a long period of time, will buprenorphine support them?
Great question. So yes, patients who take methadone can be switched to buprenorphine. What I would say is that that's not going to be the right move for every patient, but we do have protocols that guide our clinicians through doing that. It is possible. I would never force a patient to switch, but I do think if a patient is interested, because honestly, with methadone, it's not a bad medicine. We all know that. Evidence-based, really important, but it is more complicated for patients, right? Oftentimes they have to go to a clinic every day to get it, or they only can get small, if it's for pain, they can only get short-term prescriptions. They got to go to the doctor a lot. Also, we know that it can cause them to be sleepy and it does have a risk of overdose. So if a patient wants to switch, bup is a fantastic option. And yes, it does work very well in those patients. So if the patient is interested in transitioning, that is absolutely an option. And then these rules that we have for buprenorphine apply to methadone as well. You can adjust somebody's methadone dose up in the setting of acute pain. You should add medicines that are not opioids to control their pain. And we shouldn't be afraid to give patients full agonist opioids like fentanyl while they're in the hospital. We're monitoring them to keep for safety, but we shouldn't be afraid to treat the acute pain in those patients too? It's a really good question. I did not put methadone in this lecture. It's a really, really good question. Okay. I will check all the chat in just a beat, but how can navigators help specifically with chronic pain? So we talk a lot about connection to care and community, which really is our AKA navigators, sort of pillar of the bridge program. But the idea, right, that the hospital, the emergency department is not necessarily the best place for these patients to get their care, but we are a critical starting point sometimes for patients who are having unmanaged or out of control pain and they end up with us. And so what can you all do? You can think about how we connect those patients into better outpatient care. And so again, I would love if you would reach out to your referral partners, to the MAP Bridge clinics that you work with, and see how they would feel about getting a referral for patients with chronic pain. I think you'd be surprised. A lot of them will say yes. And if they do, that might be a great tool in our toolbox if you're seeing patients who have chronic pain, who are opioid dependent, or who take long-term opioids, who take, I would say, hydrocodone or oxycodone most days of the week, not even every day, most days of the week. That is an appropriate patient to be considered for buprenorphine. And so that might be a really wonderful life-saving and pain-controlling referral that you could do. So maybe do that homework this week and call your clinics and see how they feel about that. And if they like the idea, then that's a great option for you. Another one is nudge your clinical champions to do some training on pain management. Again, we do this training for free. We, the Bridge team, all of our ILs, our implementation leaders, are equipped and ready to do this training for you. We have it recorded if they want a recorded version. So send them to us. Send them to the clinical team. If you don't know how to do that, you can use info@bridge2treatment.org, or honestly, go to your Navigator mentors, go to Sherrie. They can always filter you to us, no problem. Use your normal resources. We all work very closely, so they can get you to the right person. I would consider work with your clinical champion to create a handout that helps go over those pain steps management with patients in a way that might help them to feel like they have tools, right? When our patients don't have education about what tools are at their disposal, then they don't know how to use them. And that could be a really helpful thing to have. It could even have a stepwise approach like that slide that we showed you. And maybe your doctor helps fill it in and then you counsel the patient and just like how to think about it. That can be really helpful. And then really thinking about you as a solution for chronic pain patients. And what I would do there is let your clinical teams know, hey, by the way, maybe you haven't thought to call me if you have a patient with chronic pain, but could you? Like, I don't only see people who are in withdrawal. I would love to see chronic pain patients. I would love to see patients who have some of those struggles as well. And that also just helps to elevate the profile of the amazing work that all of you already do, which offers hope and solutions and does change culture and save lives for our patients. So I will stop my screen share here and open up the chat and catch myself up really quickly. And then please, if there are other questions, go ahead and toss them in. Oh, I'm seeing so many other reasons that people tossed in that were challenges, like, for example, cultural differences. Oh my gosh, yes. Like people express pain really differently. Some cultures express grief and pain a lot more outwardly, and I will say like loudly with volume than other cultures. And that gets really stigmatized. And that's not fair. Like just because your culture expresses grief or stress out loud, right? That can lead us to have a lot of stigma. Yes, patients with comorbidities, we get afraid. Thank you, Alexandra. We get afraid to start different medicines because we're not sure how to balance those things together. You're right. People who have pain, we want to fix it. And it's really, really hard because we think that opioids work so well. And so we're afraid to go slower. We're afraid to try other things. And then, yeah, if you missed it, there's a link in the chat to the Alternative to Opioids lecture if you want to share that with your teams. All right, I'm just catching up. For patients already on BUP who might break their leg, how would additional opioids assist if BUP is occupying the receptor? That is a great question. I will try to be as non-crazy technical nerdy doctor as possible in this answer. BUP has a very strong affinity for the opioid receptor. That is true. And actually, that is what makes it safe to give opioids on top of it, is that we're not going to let go for the receptors that BUP is holding on to, okay? That said, most of the time, BUP is not holding on to every single mu receptor in our body, right? We give patients a dose until they feel better. We love patient-guided buprenorphine dosing. But that patient feeling better doesn't mean that we have to occupy 100% of their receptors. We have to reach a level in which they don't have cravings. Maybe their chronic pain is like generally under control. Their withdrawal symptoms have stopped. That's only not 100%. So I'm going to make things up. Let's pretend that for a patient to feel better, BUP has to occupy 60% of their receptors. Okay, now they're in pain. We bump that dose up and now we're hitting like 80%. We're at a fairly high dose of BUP and we're not quite cutting it. If you give a very high dose of fentanyl or a high dose of morphine or a high dose of hydromorphone, what you're doing is trying to target that last sliver and really just take away that pain, really just relieve that pain. But you left all that BUP in place so that you're not like going through these horrible ups and downs roller coaster ride. But that's kind of the concept there, is that we don't usually occupy 100% of the receptors. We occupy enough to treat the person to feel better, but there is that little sliver left. And I will say that sometimes to get to that sliver, we have to give really high doses of full agonist opioid, like fentanyl or morphine. We have to give really high doses to get there, but we can get to those. So thank you for asking that question. It's a really good question. Especially because we emphasize, right, that BUP doesn't let go as a safety profile thing. We like that. So yes, usually there's like a percentage of free floating. Would Subutex be an alternative with that patient? I'm not sure which patient you're referring to, but I'm assuming you mean this one that we're talking about with the broken leg. And so Subutex is just another formulation of BUP, and honestly, all buprenorphine. Yeah, okay, yes, thank you, Sabrina. Yes, all buprenorphine is an option here. It doesn't matter if we're talking plain buprenorphine, combination buprenorphine naloxone, long-acting injectable buprenorphine, amazing option for patients with chronic pain, whether it's a weekly or like a monthly. There's like 7, 14, and 28 dosing options for those long-acting injectables. Any and all of those are fantastic. And then same with the patch, right? So those patches too. Doesn't really matter the formulation, but any of those are good. what we love about patches and long-acting injectables is that for some patients, it really just helps give them that baseline little bit of opioid, which their body has developed dependence. And so the reason that they feel pain is actually because they're kind of going into slight withdrawal. And so hence, again, chronic pain being a spectrum of opioid dependence and tolerance and opioid use disorder. And thinking about that can make it easier to realize that we should be referring some of these patients for buprenorphine. Rebecca says, I've had a lot of pain management doctors send patients to the ED to get on bupe. Could you have a resource page on that? Honestly, that's a great point. We don't have that. I would say it's real simple. We just put people on it, like on a regular dose. And you could easily start somebody who's on pills only in more like the 8 to 16 milligram starting dose. They don't necessarily have to be in withdrawal, but we probably would wait, or else we would do the microdosing cross tapering, which again is a medically heavy concept, but probably that's the best one to do with patients. It's really hard to do outpatient. It requires a lot of health literacy. But if a MAC clinic or a bridge clinic is interested in helping, they can do that outpatient support, or a patient could be admitted to swap over and like little by little increase their bupe until we hit the dose that works for them. So that's Rebecca. I would say if you get a patient like that, that's a good one to refer to our IL team or to use that substance use disorder warm line for clinicians. That would be a really good time to refer a clinician directly for that advice. All right. Any other questions or comments?
Oh, any other questions for Alicia? We have her now. These are all great. Thank
Yeah.
you for engaging. This is like really, I told you they wanted this. Like
Yes.
we've seen a lot of chat. So, and this is not the end. You know, if you guys have questions, please reach out. We will give them to Alicia. We're always on Slack. And so, you know, always know you have support and you're not alone, even though sometimes you feel like you're all alone, but remember, we have our favorite here today. And so we're excited that we got so much engagement, Alicia, because this is, like I said, they've been asking for this and really, we really appreciate it. We put a bunch of links in the chat, and just if you didn't get them, we will add the links that she mentioned to the post-event email. So if you didn't get them here, it's fine, it's okay. We really appreciate your time, Alicia. Thank you so much. And
Yeah.
of course, you know, we're going to get requests to have you back.
It's every time if I don't get invited back, I'm worried I did something wrong. So please.
Not
Yes,
at all.
really.
Um,
What I would just throw out as a big reminder, please, 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 it is not your job to know all these medicines, but I have seen a million, it feels like, success stories where you, the navigators, nudge your clinicians in the right direction. So if you want to go to them and say, hey, we had this really cool talk about chronic pain and dealing with it in the ER. Did you know that Bridge has a clinician training about pain management? Like, wouldn't this be so cool for your ED group, for our docs and our nurses to learn? Like, please send them to us. If we got referrals out of this, that would be absolutely perfect. And it's a way that we love to support you is by helping provide that education. So please, please don't be afraid to refer everybody to us.
and it's very simple to email Alicia and ask for training info@bridgetotreatment.org. So very simple. That will go to her. We will route it. So again, if you need physician training, please let us know and we can get that referral to Alicia and the clinical team. So thank you so much.
Thank you. And
And
thank you, navigators, for everything that you do. I know that we say it every time. Well, I hope we say it every time we talk to you, but I just love to reemphasize like it is magic, the work that you do. And I have seen firsthand how many lives you have saved and the incredible stories of success. And also just what you do for the clinician wellness around you. Just what a treat it is to have all of you working alongside us. Just thank you, thank you, thank you, and know how much you are valued and appreciated because I'm sure that we don't tell you enough.
love that, love that, love that. Thank you, Alicia. All righty. So next up, we are going to do our announcements. We did not do our announcements because we were on a time frame, but now we are going to do our normal announcements. And as you know, we have several Navigator focused trainings and meeting sessions. Our Navigator update is with LaToya. She presents that monthly, and it's a half an hour. And it's really a time for you to ask questions and get real-time answers. I know sometimes we do have time at our Navigator Focus series, but really the Navigator update allows for that time, because sometimes we get to them, sometimes we don't. But again, once a month, our next Navigator update will be June 11th, and that's SUD navigation and the social determinants of health. So we'll have a really good topic, and if you have questions, bring them to that. Our Navigator Focus series for June next month is engaging special populations, veterans, and we have a new speaker, and she's a veteran. She is an ED physician, and so it's really, we were so excited to find her and talk with her. So she's going to have a great presentation next month. Chaia always has our monthly, it was supposed to be a pilot, but you guys, again, we listen to you and your feedback. The Navigator peer support is doing wonderful, and Chaia is in charge, and she's planning for Wednesday, May 28th. Please join her. This has been a really safe and it's a safe and supportive environment to share your experiences, stresses, even if you're in recovery yourself. It's all peers and it's confidential. Nothing is going to, it's a safe and confidential place for us to meet. And then if you haven't been or haven't heard about the CA regional collaboratives, guess what? I'm going to talk about them. So we have two different types. We've been coming to the in-persons and have met many of you already, but we also have virtuals every quarter. So this quarter, our regional collaborative, it is a place, very simple. I'm going to put it down. We want to expand low barrier MAT in your communities and get people together to collaborate. We hear so much from inpatient, outpatient navigators that you don't even know what services are offered in your community. So this is a great place. We invite you to invite anybody you want. We're opening our doors for our virtual regional collaboratives for all regions. So please join us. We're inviting county, we're inviting nonprofits, anybody who you know who want to expand low barrier MAT treatment in your community. So please join us on June 3rd, 9 to 10:30. And then our in-person for June will be the Central Coast. We're going to be in Monterey Tuesday, June 10th from 9 to 12:30. So it's a half a day. It's going to be wonderful. Really focused on the people in that community. But if you can't make the others, that we totally understand. We'd love to see you there. So if you haven't been on our website, please, we have the registration links up and we'll put those in the chat. Or if you want more information, definitely let us know at mentors@cabridge.org for more information. I'm going to hand it off to you, LaToya.
All right. So before going over this lovely knowledge check, I just want to respond to the question in the chat about inviting others to our regional collaboratives. Absolutely, Sabrina. Treatment centers are invited, as well as other service providers in your community. We like to ask at the regional collaboratives who's not here in the room and who should be. So when you are sharing the invitation, keep that in mind. Who do you think should be involved in that room, virtually and in person? Monterey is super beautiful. We all know that. If you haven't been there, I highly encourage you to attend the in-person in Monterey, and be in the room with us. Invite others who should be in the room. It's always such a fantastic experience. You will not regret it, I promise. Okay, so for the knowledge check, feel free to utilize the chat to answer these questions. So the first one, stigma makes treating chronic pain challenging. True or false? All right, so seeing lots of trues. Yes, that one is true. You guys are so smart. The next one, patients with chronic pain and OUD should have a unique plan of care. How do we feel about that? All right, yes, again, more truths in the chat. So yes, that is correct. It is true. The third one, there are non-opioid and opioid treatment options the medical team can discuss with the patient. Yep, right. You guys are so on it and you really pay attention. That's so wonderful. So that is true. Absolutely. The fourth one, people with chronic pain should expect to feel pain-free. Okay, see, I try to be a little bit tricky with that one. So you guys caught it. You're definitely on it today. That one is false, right? We want patients to understand that there may be still some pain. So expecting to feel pain-free is not the direction that we go. Oops. And then number 5, buprenorphine does not help with pain management. How do we feel about that? Yes, absolutely. So all in the chat. Oh wait, actually, hold on. Yes, that is false. Okay, wait a minute. Buprenorphine does not help with pain management. That is false. Absolutely. That is accurate. That is false. We just heard from Dr. Alicia Gonzalez that buprenorphine can and does help with pain management, with managing pain. So absolutely. Thank you guys. Right on it. All right. And so we do have a number of resources. Resources were shared in the chat today, including the video on alternatives to opioids, also known as Alto. So amongst so many other resources on our website, visit our resource library, including our CBridge Academy, where yourself as CHWs and as navigators, peer support specialists, nurses, and physicians can all receive training on our CBridge Academy. CME is available on our CBridge Academy, as well as CEs for many of the others that I just listed. Also, we'll take a moment. You can screen or take your phone out and grab that QR code and then share it with somebody today. Share it with whoever you think can benefit from taking a look at our website, taking a look at our resources, and maybe moseying their way on to the CBridge Academy. And as I speak about it, here's our plug again about the CBridge Academy. So free CE and CME. That is the very operative word here, is that everything we provide for you is completely free of charge. And it helps you be able to advocate for the care of patients when your providers have this education and this knowledge. Maybe they don't feel exactly comfortable with some of the changes that are going on. Direct them here. They can get the same training from Alicia and from some of our other providers on utilizing MAT for patient care. You can contact us at mentors@cabridge.org. We typically have a really quick response time, usually within an hour, I would say 2 at max. So when you have any questions, comments, concerns, you want to tell us how fantastic you think we are, we want to hear it. So just reach out to us in our email, mentors@cabridge.org. These are your part of your mentor team with the Navigator team. So myself and Chaia we are always available. Please reach out to us as well. We can answer questions. We can help direct you to the right resources, all that good stuff. And our lovely director, Sherrie Cisneros. This is her contact information. Again, reach out. We are available to you all for any questions that you have and anything else that you need as far as support. And that's all that I have. I do want to, since we have a few minutes left, we can certainly end now. But I also want to leave a little bit of space to answer any lingering questions that might be there. Now is your opportunity to ask those questions. So feel free. And if not, have a great rest of your Thursday.
Thank you for attending, you guys. Thanks for everything
Yes.
you do.
Thank you.
Enjoy your long weekend. Yeah.
Okay, can you show us the Sea Bridge Academy info? Absolutely. Let me go back a couple of slides. There we go. And there's a nifty little QR code there.
And the
Wait, am I
evaluation,
sharing?
just to remind, just to remind
Hold on, I'm
everybody,
not sharing it, sorry. There we go.
the evaluation will have the information that was shared today, as well as the slides and any links. So look for in your email, the post-event email. So that is going to be a wealth of information, and that will be coming soon to you.
I think that's all the questions in the chat. So again, thank you all for joining us. Please continue to do the wonderful work that you're doing. Don't forget some self-care. Have a great holiday weekend. And we'll see you at the Navigator update and the regional collaboratives and the next Navigator focus series. Bye.